So we're going to look at the nervous system of the heart while Jill works out which toxin it is that she's suffering from. So the nervous system of the heart is affected by means of a balance of power of the two divisions of the autonomic nervous system, with the result of the opposing stimuli received from the sympathetic and the parasympathetic nerve. Now luckily, parasympathetic-wise, it's only one nerve. It's the vagus nerve, which is the most important parasympathetic nerve that comes through from the head here, down, loops round over the atlas, from the foramen round over the atlas, down on the left side and the right side. And it controls the swallowing mechanism, the posterior part of the tongue, the breathing mechanism. In other words, it regulates the bronchial, not only the tubes but also the arteries here. It regulates the heart, and it regulates most of the gut right down to the descending colon. Okay? So virtually all the organs in the body are regulated in some extent by the vagus, which may operate the blood supply to them, regulate the blood supply, and or the control of the organs themselves through the parasympathetics. And it's now discovered that probably the vagus is 80, maybe even 90% afferent. Okay? So we always think it efferent, controlling, but in fact now it's being discovered it's as much, if not almost 80, 90% afferent. So in other words, it's feeding information back. So small stimuli to the vagus nerve in other locations go back to the head, and then it regulates back there, or is modulated in the head, and changes the heart. Okay? Now a good example of this is a good bit of wind. A good bit of wind, which many of our patients suffer from, distends the gut and can stimulate the vagus nerve. And as it stimulates the vagus nerve, we're going to learn that the vagus slows the heart down, and the people faint or syncope. And this is called the vasovagal reaction. So they get a problem in the gut, they get wind in the gut, and then they feel dizzy. And then eventually the blood pressure drops and down they go. They also discover and know that when you move any organ in the body or tissue in the body, those muscles refer symptoms back, information back to the brain, which is reflected back into the heart rate. So you see this in the heart. So small changes of body motion, body movement from particular organs and muscle tissue will change heart rate. The heart rate variability goes up, down, or less coherent, and also the depth of the beat. So the rhythm changes, and also the depth of the beat. So the heart is a reflection not only of what's going on in the heart itself, but a reflection of the brain through these mechanisms like the brake and the pedal. So the sympathetic and parasympathetic. What have you found there?
Toxic metals and chemicals.
Toxic metals and chemicals. So toxic metals, as we'll see, are toxic because they displace good metals or nutrients, which act as cofactors to activate enzymes and proteins in the body. What was the other? Chemicals. Chemicals can interfere almost with anything. Okay, so chemicals can be toxic in many different ways, but most are because they inhibit enzymes from functioning properly. Could be worse, could be actually affecting the gene. But we want to look at the relationship, particularly of toxic metals, and where toxic metals actually cause their inhibition of why the nerves don't fire properly, which is what we want to see with our patients. So I'll carry on here. You find a good antidote, which will probably be a herb. So the sympathetic tends to speed up and increase the circulation of the blood in response to physiological demands. Okay, now this is interesting. So we know when we've got to get across the road, we need to open up our blood vessels, we need to open up our tubes as far as our lung is concerned, but we want to shut our gut down, don't we? We don't want to get halfway across the road and think, oh, I could do with a bowel movement now. Okay, we want to shut all sphincters, stop the peristalsis as much as we can, speed the heart up, increase the size of the beat, and get across that road. That's the sympathetic response. Now the opposite to that would be the vagus stimulation, which is in many ways the brake. So it puts the brake on the heart, but interestingly, the sympathetic system actually opens up the blood vessels in the heart, okay? Because we need more blood to the coronary vessels, to the myocardium, the muscles of the heart. So sympathetic activity increases the blood flow to the heart. This is interesting, isn't it? Because stress, in other words, is good for you. Okay? So that brings us back to what all the papers have been saying during the week, isn't it? That stress in the way of anger can be a predictor of cardiovascular disease, because for as long as 2 to 4 hours after a good rage, you're in greater risk of a heart attack or a stroke. And when they were asked, why is this? Because this is revolutionary. Nobody's ever thought of this before, have they, that anger could cause cardiovascular problems. It's been documented for at least 50 years or more, but this is now a meta-analysis, so it's better than anything else. Is why? So they said, well, we know that stress increases blood pressure, and that's not good for hearts. But that doesn't necessarily predispose a person to a heart attack. Oh, stress increases or alters the lifestyle of the person, and they tend to smoke and drink more. And that's the reason they get it. You've got to come up with a better excuse than that. Because if you're having a stressful reaction, you're having high noradrenaline, you actually open the blood vessels up. Who shuts the blood vessels in the heart down is our friend the vagus. So this is different. So maybe there's a different mechanism, which we'll see later on, that the predisposition to the heart attack may not be noradrenaline. It could be acetylcholine or the acetylcholine receptor. That when you increase the parasympathetic vagus activity, you slow the heart down and you narrow the coronary vessels. Okay? And this has been shown to bring on heart attacks when they've administered acetylcholine. So now we've got to think of which emotion increases acetylcholine. So we'll come back to that later on. So the former being the accelerator, the latter the brake. Now, the heart beats. You're all familiar with the fact the beat. The two auricles contract almost simultaneously and are closely followed by simultaneous contraction of the ventricles. The entire cardiac cycle means the beginning of one contraction to the onset of the next. We've gone through that one. Normally, the whole cycle is about 0.85 of a second. The cycle is divided into the various time intervals. The contraction of the heart is called systole. The auricular systole and ventricular systole. However, the term cardiac systole is used when it refers to the contraction of the ventricles. The relaxation time is called diastole. The heart differs in that it has a specific type of tissue not found anywhere else in the human body. This tissue instigates the originating and conduction of the heartbeat. It is referred to as the neuromuscular tissue of the heart. So where this occurs, this origin, is in neuromuscular tissue, which is unique to the heart itself. The reason for this is that it resembles both nerve and muscles. Okay? One important area is located in the apex of the right auricle between the inferior and superior vena cava and is called the sino-auricular node, better known as the a.v.node to you and I. So here we are, right in the top part of the right auricle. In the muscle tissue there is the a.v.node, and everything comes from the a.v.node. Okay. It's the Big Bang, 72 times a minute. So the electrical conduction, and nobody knows why. Okay. It's inherent. Okay. So it starts at 5 to 6 weeks in utero, very, very early embryologically, and finishes with the last beat. So, number one. Number two is the second emanation, called the a.v.node. So conduction goes from number one, the SA-node, to the a.v.node. So it goes down that way. And then goes down the bundle of His, Purkinje fibres, etc., that we'll learn about. Now, where are these points? Because we know when we listen to a heart and where the actual valves are different locations. Okay, we don't listen over the heart valves, we listen to where we can hear them best. And it's exactly the same with the SA and the a.v. nodes. Okay? Now, we're looking for somebody or a patient who has an arrhythmia. Okay? Because this is to do with rhythms, isn't it? Okay? This firing, these things are called the pacemakers, and the SA being the most important one. Okay, we're looking for somebody who has an arrhythmia. When we have a patient with an arrhythmia, they will probably be a blue person, but could be expressing aspects of the blue. And we look for it at this exact same point that we've been listening, at Erb's point, which is in the third intercostal space, okay? Just on the left. And just below that, one rib space, lateral, is the AV. because we're looking at the sounds coming from the auricle, right? These are where you hear the particular cardiac sounds, but this is where we therapy localize for the actual notes. Now, so if you wouldn't mind just therapy localizing, you can leave the emerald on. We'll take her headphones off because we'll do this in the clear. Okay, so she's going to have to now therapy localize on that point where you're listening to, and let's see what happens to her. So she's tested it on either side. So she's going weak. Now stay there. All right, now put the a.v.node on. So the a.v.node is the marker here is okay. Now try the a.v.node. The a.v.node only comes in, as we'll see, when the a.v.node isn't functioning properly. So usually the a.v.node is not going to create a problem. She's going with a. She's weak, yes. So she doesn't strengthen to the a.v.node. Okay. Now move her down one rib and out a little bit. That's it. To the a.v. point. Sorry. She's strong, yes. So she strengthens to that point. So she's not strengthening, she's not weakening to it, yes. Because her problem is at the a.v.node. This is very familiar with arrhythmias, anything which is actually happening apart from fibrillations, as we'll see. So when you get your atopic beats, you get your drop beats, you get your extra beats, and a lot of paroxysmal tachycardias, that something's happened to the a.v.node. That's when they come into ablate. When it's really serious, you have the ablation. Or a new pacemaker put in. And they can get that in no time at all. You can be directed to the cardiologist, and before you know it, you've got a new pacemaker put in. Whether you need it or not, really, the cardiologist said you've got to have that. You have that ablated or a new pacemaker put in. Right, now while we were there, experimenting around with patients, we found another very interesting point. Okay, now does anybody have blood pressure? I know you do. Anybody else have a problem with blood pressure? No? So should we see what your blood pressure is like? Okay. So can we just swap you over a minute? We'll come back to you, don't worry. We won't leave you suspended there. What did you find as a herb with her? Yarrow. Oh, lemon balm, okay. Okay, so if you pop down on your back. So this is a point for hypertension. We found this very useful indeed. Now this is a point, the point between the nipples here is the conception vessel 17, is it? 17, okay. So go up one. I don't know whether it's 18, but go up one. Oh, 18 and a half. Okay, yeah. It's a funny position, but I just say find the point between the nipples and go up a bit. And she goes, watch this, how she goes weak. Okay, this is a wonderful point when people say, you know, I'm not sure, I've been told I got high blood pressure. What's your blood pressure? Oh, 130 over 85, I'm on all this medication. Really? Yeah, I've been told I've got to get down to 110 over 70, you know. So the question is it high blood pressure for that person? And I've tried to strive for many years to find a point or a way using kinesiology to be able to determine whether the person has high blood pressure or not. And this is a very, very good point. It's consistent, and from that, you can just go off that and do your various eye positions and things and find out what she needs or what she doesn't need. Okay? So you can immediately see if it's something she's eating, if it's a toxin, if she's deficient, etc. So without going into the whole sort of program, you can immediately help someone who's got a hypertension. On the other hand, if they don't weaken to that, that blood pressure is probably normal for them. Okay? Now, like the phonocardiograph and the medication and the nodes, the pacemakers, medication doesn't do anything. Okay? It may help them to live a bit longer, but if a person's got hypertension, they will still show to hear even if they're on drugs. Okay? Because the drugs hasn't solved the cause of the hypertension. It's reduced the blood pressure through blocking one means or another, whether it's beta blockers, ACE inhibitors, calcium channel blockers, etc. So it's not solving the problem. If the person needs magnesium, they need magnesium, don't they? So it's not going to solve it. And if they have a pacemaker, and that pacemaker is being aberrant because they're eating monosodium glutamate, it doesn't matter how much you ablate it or have medication for it, it's not going to make any difference if there's a toxin, which could be a metal, it could be a chemical, etc., that's causing that problem. Thanks, Dinkner. We'll have you back later.
Yeah.
So use that point to help monitor people whether you're effective with your treatment. Is your treatment being effective for the blood pressure? And the answer is yes, if that loses its therapy localization. Now, as I was described before, to me, a therapy localization for something good or bad should have a positive or an effect in both brains, the left brain and the right brain. We know we work predominantly from one brain or the other, but of course we're working with both brains, but one tends to be working a little bit more than the other where we're coming from. So with a therapy localization, it should be bilateral. So with Dibner and with your a.v.node, Jill therapy localization used both legs, okay, so in other words both brains, and she went weak on both sides. If a person weakens on one side only to a toxin or therapy localization, this is, I would count this as an adaptation to a problem. This is not the problem. If you're getting a TL off one side, one area only, and not the other side or not the other brain, this is not the problem. This is the result of the problem. Okay? The problem will bilaterally, it'll weaken everything. So if a person shows up that they've got toxins or chemicals, but it's only weakens on one side to the chemical, the chances are the chemicals are caused by something else. And 9 times out of 10, that will be parasites. So parasites would be your primary thing that they weaken bilaterally to, but the parasites are producing chemicals which are picking up in the body and causing inhibition. And believe me, a lot of heart problems, arrhythmias, are caused by parasites. You get that ammonia and that phenol and sometimes toluene with nematodes into those pacemakers, the electrical conductivity, and it will create havoc in there. You know, it's well known ammonia creates nephrotoxicity, but it creates neurotoxicity. Okay? You can imagine what ammonia is like in the brain. If you have a sniff of it, you feel a bit squiffy. You give a sniff of it to your heart and see what happens. You know, how do you like that? Remember, the heart is neurological. It has wiring, it has electrics, and those electrics go to these very specialized areas which are highly sensitive to changes in the blood chemistry and the electricity. So those are the points we use. So everybody with any form of genetic or, in other words, rhythmical disturbance, we go for the a.v.node and the a.v.node. And what we've just got to learn is what is the significance of one or the other? What sort of problems are caused by the a.v.node and what are by the a.v.node? Okay, so another similar node that's to the a.v.node is located in the septum, the partition dividing the right and left side of the heart, between the auricles, just above the ventricle, and extends down into the septum between the ventricles. This is referred to as the auricular ventricular node, or what we call the a.v.node. So for simplicity, we call it the a.v.node, which is where it all starts from, and the a.v., which is like the backup or the reserve. From the a.v.node, a bundle of neuromuscular tissue called the bundle of His extends down the inter-ventricular septum and divides the heart into 2 halves, and therefore it has 2 branches, because that then goes into the muscle tissue. So that's the bundle, or the bundle of His. So when we get a blockage in there or misfiring, it's called a bundle branch block. Okay, so that's where the bundle branch block comes in. So it's a block between the a.v.node going down in the firing down towards the muscle tissue and the Purkinje fibres. Purkinje fibres branch out extensively through the ventricle muscle. The first part of the heart to begin its contraction is the right auricle from the SA-node. So here we see the SA-node going to the a.v.node, going down the bundle, and then into the Purkinje fibres, which are in the tissue of the heart. See how thick this tissue is, particularly on this left side. See, the right is relatively thin, isn't it? But this right one is really thick. This is the real working part of the muscle of the heart, so it's really thick. And then that muscle tissue itself can contract inherently when all else fails, which is amazing. It takes a lot for the heart to stop, but it can be done with good practice and no abuse. So at regular intervals, a wave of contraction spreads across the SA-node out from the auricles, as we know, at roughly 72 times per minute. So the contraction wave in the auricle, that's from the SA-node, it travels at a rate of 1 meter per second. So that's quite fast. Okay, but in electrical terms, it's not that fast. So from the the SA to the AV is 1 meter per second, but of course it's only a short distance. When it has passed over the auricles, it reaches the AV node at the junction between the ends. The conduction at this point of in the AV node is slower, being only 10 to 15 centimeters per second. So from there, in other words, to the bundle is very slow, and there's a very good reason for this. Okay? So it's much slower. So if anything happens to your SA node, your heart goes to rely upon your AV node, and that slows the whole process down. So your pulse rate and everything will drop right down. So if you only rely upon your AV node and your SA node is being ablated, you'll get because your conduction time is that small. But there's a reason for that. The cardiac impulse is therefore delayed. The delay is responsible for the pause that occurs between the completion of the auricular contraction and the beginning of ventricular contraction, and this is referred to as the AV pause. When the stimulus reaches the bundle of His down between the septum and the Purkinje fibres, conduction is speeded up again to 3 to 5 meters. This is really fast. Okay, so once we're into the bundle, so you can see when you get a bundle branch block, we're looking at a very, very fast. But from the AV node, when you get a bundle branch block, it must be the AV node which is not transmitting the information to the bundle at an equal portion, at an equal rate. So the rate being 3 to 5 meters per second, with the result that the impulse reaches all parts of the ventricle muscle almost simultaneously. Therefore, it differs from the wave-like contraction of the milking fashion of the auricle. The importance of the specialized neuromuscular tissue of the heart is apparent when realizing that if it were not present in one part of the ventricle muscle, would have finished contraction before the other had begun. So this is why it has to be so fast in that den. So we've done that. We talked about that. We've seen the valve.